Good morning. Today we'll be starting our session, that is building your foundation strong. So as we all know that glaucoma is the leading cause of irreversible blindness. There are various skills and diagnostic techniques so that we can identify glaucoma early and prevent blindness. So we have various speakers, and I invite Satyan sir to come and sit. It's okay.
So Dr. Nimita will be presenting gonioscopy, unlocking the angle and revealing glaucoma secrets. She is a consultant from Comtrust Eye Hospital, Calcutta.
So I'll be talking on gonioscopy. So primarily gonioscopy is basically done to differentiate open angle from angle closure disease. And this is the gonioscopic picture of open angle. Whereas when there is an iridotrabecular contact, the angles are closed and none of the structures get visible. So the concept of gonioscopy, usually we cannot visualize the angle structures due to total internal reflection, and gonioscope lens eliminates this total internal reflection. And why is gonioscopy important? Because to identify primary angle closure disease from open angle, as primary angle closure disease has more risk for blindness. So what are the things required for gonioscopy? One is the dark room, the small slit, and the Goldman 2 mirror lens. So first we put paraffin in the patient's eyes, and we make sure the patient's chin is resting on the chin rest, and the forehead should be touching the slit lamp forehead band. And with the help of the gonio lens, you ask the patient to look up and make the illumination less, and with your forefinger or a swab stick, you place the gonio lens. So this is how the gonio lens is being placed. Other than that, we can use the viscous agent also. So there are two types of gonioscopy, that is the direct as well as the indirect gonioscopy. In the indirect, there is the non-indentation and the indentation. The indentation is where the surface area is larger than the cornea, and we use the viscous gel, whereas the non-indentation, whereas in the indentation, the surface area is smaller than the cornea, and the patient's tear film is used. There is other different types of gonio lens available, that is the Goldman single mirror, Posner, and Sussman is also available. In direct gonioscopy, we make the patient lie supine, and we place the gonio lens such that the angle structures are visible. The various lenses available are the Swan-Jacob, Copies, and the Barkins. For Copies, we require a handheld slit lamp. The structures visible through gonio lens, that is this darkish band which is visible, that is the ciliary body band. Then there is the scleral spur. Then there is the trabecular meshwork, that is the posterior trabecular meshwork. Then there is the anterior, and then anterior trabecular meshwork, and then there is a Schwall baseline. So it is important to make a corneal wedge. The corneal wedge, basically, you hold the slit lamp at a 30, the two arms of the slit lamp should be made at a 30-degree angle, and then you identify the, you make a thin slit, and there will be these two other thin slit, and one is from the corneal endothelium and the other one is from the corneal epithelium, and where the line meets, that is the Schwalbe's line. If the structures are visible beyond the Schwalbe's line, that is indicative of open angle, and if the structure is not visible, that is indicative of closed angle. And here you can see a double hump pattern, that is indicative of a plateau iris. So in this gonioscope, you can see that you feel that these angles are actually closed. But when you make a thin slit and you identify the Schwalbe's line, actually the angles are open. Then this is a gonioscope picture where you can see a uniform pigmentation of the trabecular meshwork, and you can see a Schwalbe's line and the concave iris configuration, which is all indicative of pigment dispersion syndrome. Other than that, you can see in this gonioscope picture, there are small white fluffy dandruff-like material and patchy pigmentation of the trabecular meshwork and the Schwalbe and the Sampolicis line seen, which is seen in pseudo-exfoliation syndrome. So here the angle structures, here in this gonioscope picture, you can see the iris is coming in contact with the trabecular meshwork. The trabecular meshwork is coming in contact with the Schwalbe's line, and as a result, none of the structures are seen. And this is basically a peripheral anterior synechiae which is seen. And this peripheral anterior synechiae is usually broad, irregular, and it reaches only up to the trabecular meshwork, and none of the structures are visible. So in this, you can see that the angle is actually closed, and you can see a volcano-like configuration, that is the Fuji sign which is seen. This is the lenticular mechanism of angle closure. In this video, basically, none of the angle structures are visible, but as soon as I press over the cornea, you can see few of the structures visible. So if none of the angles, if few structures are visible, it is indicative of appositional, whereas none of the angle structures are visible, it is indicative of synechial angle closure. So the new vessels, they are usually fine arborizing, and it usually crosses the scleral spur. So here you can see that there are fine new vessels seen in gonioscope. This is a gonioscopic picture where you can see prominent iris processes and Schwalbe's lines seen. That is indicative of accent field anomaly. This is another gonioscopic picture where you can see the ciliary processes and also an iris stump indicative of aniridia. This is another gonioscopic picture where you can see a widened ciliary body band seen in angle recession. This is a gonioscopic picture of a foreign body seen in the angle. It's a glass piece seen. This is another gonioscopic picture where you can see the ostium and a large iris, large peripheral iridotomy done in post-trabeculectomy. This is a gonioscopic picture of silicone oil seen in the angle. This is another gonioscopic picture where you can see eye stent and also tube in the angle. So for sterilization, we usually clean the gonioscopic lens with running water or 70% isopropyl alcohol. So to summarize, first when you do a gonioscopy, you identify the Schwalbe's line, you enumerate the structures. If you can see the structures beyond the Schwalbe's line, it is indicative of open angle. Other than that, it is angle closure. If you indent, if the angle opens up, it is a positional closure. If it is not, then it is synechial or plateau iris. And this is a diagrammatic representation. We usually use the Schaffer's grading, where grade 0 is closed and grade 4 is open. And contraindicated gonioscopy is usually contraindicated in painfully inflamed eye, acute angle closure glaucoma with edematous cornea, or suspected open globe injury. Thank you.
Next is Dr. Roshna Ahmed from Vitrust Eye Hospital, Calicut, on anterior segment OCT.
Hello, good morning. My topic is KSOS024 peering into the anterior segment. This is the angle of anterior chamber. We all know the angle, the structures. We can see the ciliary body, scleral spur, anterior to scleral spur. We can see the trabecular meshwork and the Schwalbe's line. This is the area of main angle aqueous drainage occurring. So this area can be seen with our anterior segment OCT. So anterior segment OCT is the higher resolution anterior segment imaging modality. It has long coherence interferometry of 1310 nanometers. It has spatial resolution of 10 to 20 micrometers. It is done in a non-contact. It is done in sitting position. The principle is same as the other OCT, Michelson interferometry. What is the application of KSOS024 in glaucoma? It is mainly used in the screening of the angle closure glaucoma. So reference point taken is the scleral spur. And the change in the curvature of inner surface of angle or inward protrusion of sclera between inner scleral and corneal curvature is the scleral spur. So it is the surrogate of the trabecular meshwork. So the trabecular meshwork is situated anterior to the scleral spur. So in the scleral spur is mostly visible in the nasal and temporal quadrant while compared to the superior and inferior quadrants. What all parameters we look in the KSOS024? First one is the anterior chamber depth and anterior chamber width, and angle opening distance at 500 micrometers and 750 micrometers. The Indian study by Nida Gan and Prakash Agarwal showed that angle opening distance is 0.430 plus or minus 0.137, and temporal it is 0.433 plus or minus 0.177. According to Shabana et al., it is told that measurements at distance of 750 micrometers are more accurate than 500 micrometers due to a large scan region and lower susceptibility to iris irregularities. And other thing is the angle recess area of 500 and 700 micrometers, trabecular iris pet area, and trabecular iris contact length. Hence, trabecular iris angle and scleral spur angle. This is the anterior segment OCT of a open and closed angles. We can see the angle structures are closed in the second picture when compared to the first picture. And in plateau iris, we can see the central AC depth is adequate, but the peripheral AC depth is shallow, and the anterior rotational ciliary body we can see. And in large lens, we have to look for the lens vault. Lens vault, we have to draw a horizontal line connecting the scleral spur to scleral spur, and a line is drawn from this line to the lens anterior lens capsule, and this width, that is the lens vault, if it is greater than the 1/3 distance from the corneal endothelium to line drawn connecting the anterior lens capsule, the lens vault is high, so we have to suspect the lens mechanism of the angle closure. And we can also look for the pupillary block due to phacomathic lens using the anterior segment OCT. And a study done by Anders showed that anterior angle opening distance of 750 was highest in the plateau iris group and lowest in the thick peripheral iris group. And TISA 750 and TISA 500 also showed high in the plateau iris. This is another female presented with a bilateral angle closure with symptoms of headache and vomiting to our hospital. In this patient, the IT was very high and gonioscopy was not done due to corneal edema. And in these patients, we done a ASOCT and it showed the ciliary effusion. So we thought of the topiramate and asked for the history. There was a history of topiramate intake 1 week back. And in trauma cases, we are suspecting any angle recession, we can go for the anterior segment OCT and we can look for it. And also we can use the SOT to rule out the cyclodialysis cleft and cyclodialysis. And in pigment dispersion syndrome, we can look for the reverse pupillary block sign. And other application of associating glaucoma are efficacy of laser PI and laser endoplasty we can look, and to patency and position of GDT can be looked, and to image the bleb, and we can also take after image after post mix. And in trabeculotomy, we can look for the bleb wall, the subconjunctival fluid space we can look, and the scleral flap and sclerotomy size we can be seen, and iridotomy areas we can see. And also we can look for the internal cavitary height, bleb height, and extent of the bleb we can see using anterior segment OCT. And in GDD also we can look for the position of GDD, whether it is positioned correctly, and we can check. And post mix also it is very useful. We can look for the bleb after the post mix. And in postoperative flat chamber malignant glaucoma, we can take SOCT and we can plan the B scan and everything after that. And iris tumors, cyst and neoplasms also we can take SOCT. It is the first picture is the before brachytherapy, and second picture is the 1 year after brachytherapy. We can see the lesion has regressed. And it is another patient who came to our hospital with a suspecting the iris metastasis. In this case also we can take an SOCT and look for the extent of the metastasis and whether it is extending to the ankle we can look. So ASOCT versus gonioscopy, a study done by Singapore Eye Study, IDC study showed that angle closure is by ASOCT identified 98% closed angles on gonioscopy, but 142 individuals on ASOCT found additional 45 subjects to be closed who felt open on gonioscopy. So its specificity is 54.4%. But according to their interpretation, it is said that 45% normal population can have false positive result on ASOCT. So we need gonioscopy to confirm the angle closure, not on ASOCT. What is the most biggest disadvantage is that we cannot image the ciliary body, and that is in the UBM we have to do. The posterior structures posterior to the iris, the structures posterior to iris we can be imaged in this ASOCT, but it can be done in the short time and less expertise. We can done it in the sitting position itself. Patient sitting position we can do. And we'll compare to the ASOCT and UBM. The most important difference is that UBM can visualize the structures posterior to the iris pigment epithelium, but ASOCT we cannot. But in ASOCT we can have the wider field of view while compared to the UBM. Thank you.
Next, Dr. Revati. She's a consultant at Contrast Eye Hospital, Talcheri, and she'll be talking on OCT.
Good morning. I'll be presenting on OCT, Glaucoma spectralis, Heidelberg Engineering, no financial interest. As we all know, glaucoma is a diagnostic puzzle. About 40% of the retinal ganglion cells are lost at the time of early visual field defect. So we need a pre-perimetric tool to diagnose glaucoma before that. The principle of OCT is been already defined. Coming to the retinal ganglion cells, it occupies the inner layer of the retina with the dendrites forming the inner plexiform layer, cell bodies forming the ganglion cell layer, and the axons forming the nerve fiber layer. Together this constitute the ganglion cell complex. About 50% of the retinal ganglion cells occupy the perifoveal area of the macula. So any modality, with this modality, if there is a decrease in the thickness of the perifoveal area, we can get a clue towards glaucoma. But we know this area will be made by other pathologies like diabetic macular edema, decreasing in specificity. So the best way is to examine the entire length of RGC by measuring the NRR thickness at the optic nerve head, retinal nerve fiber layer thickness, and macular thickness. The optic nerve head is identified in the OCT as a highly reflective layer, and the termination of Bruch's membrane is known as the Bruch's membrane opening, which represents a stable opening through which all the axon exit the eye, and in OCT this is regarded as the disc margin. And the perpendicular distance from the termination of the Bruch's membrane to the internal limiting membrane is called the minimum rim width, which gives an accurate measure of neuroretinal rim. So for the analysis, a 24-line high-resolution radial scan is acquired, and it is given as a sector diagram and a flattened diagram, which will be falsely color-coded. And the green line here indicates the database, the black line indicates the patient data, and the gray line may be sometimes present, which will indicate the follow-up scans. The color coding is such that about 5th percentile of the eye above the reference base will be given as green, and borderline when it is 1 to 5 percentile, and outside normal limit when it is less than 1 percentile. The retinal nerve fiber layer analysis is done with a 3.5 circular scan. Similarly, it is represented like a slightly double hum pattern with the TS and TI being the thicker layer. Again, it is the green line is database and the black line is the patient data. And the structural assessment of macula is by a volume scan, which is placed at the posterior pole, which will be aligned to fovea to BMO center axis. And in the macula, we can have various scanning techniques like posterior pole thickness map. Here you can see there is a warmer color which is representing the thicker area, and the cooler color representing the thinner area. And this area, there is we can say it look like a donut. The posterior pole hemisphere asymmetry analysis, where the average retinal thickness of one hemisphere is compared with the corresponding thickness of the opposite. If the squares appears gray in one hemisphere, the retina in the square is thinner than those corresponding to the opposite hemisphere. If it is pitch black in color, that means the thickness variation is around 30 microns. Next, we can individually assess all the layers of the retina, like retinal nerve fiber layer, ganglion cell layer, and inner plexiform layer. And these regions are again color coded according to the database, and the deviation from the database is again color coded. For example, the thickness map will be giving a warmer color for thickness, and in the deviation map, that area will be green in color. The normal retina will be appearing green in color. When there is a variation from the database, that is deviation from the database, it will be given a warmer color. Like here you can see an inferior thinning, and it is given in a red color. This is for the ganglion cell. So coming to the interpretation of an OCT report, first we should see the reliability, assess for artifacts, RNFL and MRW baseline assessment, and macular assessment. There are various errors associated with the scanning technique, and we should keep in mind about the green disease. That is, green disease means all the green is not doesn't exclude glaucoma, and all the red doesn't include glaucoma. For example, errors associated with the optic nerve head scan, here you can see they use a 3.5 circle. So in the myelinated nerve fiber layer, there is no segmentation proper, resulting in a thicker retina. When we use the 4.7 circle scan, you can see the retinal thickness is comparable with the database. Next, associated with the PVD, you can see the segmentation is not again proper here. The inner plexiform layer and the internal limiting membrane is not segmented, resulting in a very thicker retina. Even though the disc is and the visual field are showing glaucomatous changes, the OCT appears all green in color. Next, again the same, the poor delineation of the internal plexiform layer resulting in a thinner retina. If you just look at the sector diagram and the Tisnit map alone, you can diagnose this as a borderline thinning. But when you see the IR image, you can see there is no much cupping, and the A-scan quality is very poor. So ideally, we should repeat the scan before jumping to diagnosis. A case of where you can see a disc with inferior thinning and the visual field is not so reliable. The OCT is being done and it shows like a borderline in the sector map. But when you see the Tisnit diagram, you can see there is a definite dipping into the outside lumen limit. And when we go for the macular analysis, we can see the donut being eaten up. There is a definite thinning inferiorly, and this changed the management of this patient. Another example is you can in the disc photo there is definitive superior and inferior thinning, but the OCT is showing only green image. This is because the database of the OCT is inadequate to produce a trigger an outside normal limits data with this 141 microns or 14 percentile. Another example is when the patient is having a definitive superior field defect and inferior retinal RNFL defect and inferior notching, but OCT is again green in color. This is because of the retina is very thicker here, maybe because of the diabetic macular edema. We can also assess the progression analysis with OCT. Here you can see the global thinning from 50 to global thinning which progress over the years. Also, you can use an OCT posterior pole assessment. You can see the whether this area is thinned out. The thinner deviated area will be shown in red color. Here you can see the donut being eaten up like from here to here. To summarize, the whole report should be evaluated including the raw data. Output data should be consistent with the clinical presentation. Distinguish the major artifacts. Ensure the optic disc, RNFL and macular analysis are consistent with each other. Thank you.
Next speaker is Dr. Vishnu. He's a glaucoma consultant at Ashwini Netralaya, Tripura.
Good morning, everyone. I'll be talking about the topic how to focus on the points of Humphrey field analysis to reach at a proper diagnosis. So we all know standard automated perimetry is what we use to see the central 30 degree of the field. Basically, we are seeing how much sensitivity is measured in all the points of the retina. So basically, there is a threshold. We calculate the threshold, which is actually 50% of the 100 stimulus given. Patient is supposed to get 50% of the stimulus, and patient is supposed to miss the 50% of other stimulus. And 0 decibel means maximal stimulus intensity is used, and 50 decibel means 0.1 minimal stimulus intensity is used. So things to watch, we have to see the proper ergonomics of the patient if they are seated properly, and the testing programs include 30-2, 24-2 and 10-2 macular program, which measures the points 76, 58 and in 6 degrees apart. And the strategies include full threshold, CETA standard, faster and fastback. So these are the point distribution we all know. So what is the Humphrey field analysis? It's divided in 10 zones, zone 1 to 10. Zone 1 include patient data. So basically, we are comparing the age-matched individuals. Patients' data is compared to the age-matched individuals. So the age is important. Second point is refraction. Refraction is important because even one diopter variation causes 3.6 decibel generalized depression in the perimetry. Then pupil diameter should not be less than 3 millimeter because again there will be decrease of the sensitivity. Stimulus size normally used is Goldman size 3 stimulus. Then background illumination used is 31.5 apostilus, which is used to saturate the photoreceptors, so that the test is done in a photopic condition. Then we use full aperture lens as well as the liquid crystalline lens. Then coming to the reliability indices, fixation loss less than more than 20% makes it reliable because stimulus is given to the blind spot. So it's the total number of times the patient respond to the stimulus divided by the total number of presentations. So intense stimulus is presented to the physiological blind spot and the patient is not supposed to see that. And fixation loss is calculated by Hegel-Karakull method, which is about the 5% of the total throughout test. So other methods include gaze tracker, in which infrared light is projected onto the center of the pupil. So false positive, which is most important. False positive indicates that he or she is seen a stimulus when one was not actually presented, and more than 50% shows poor reliability. So this presents as white scotomas because of a trigger happy patients, or it can present as an inverted cataract pattern in which there are more points in the pattern deviation probability plot than the total deviation probability plot. Now, false negative, it's a failure to respond to stimulus that is at least bright or brighter than the one which was previously the patient has responded. It shows the patient's fatigue, and more than 20% shows poor reliability. So So this shows a cloverleaf pattern, high false negatives. Then foveal threshold, if there is a 1 dB fall for every decade, and normally it is 35 decibels, then zone 3, which is used to educate the patient regarding how much of the field loss for a layman perspective of view. The zone 4 includes the threshold values, which is actually the measured retinal sensitivity of the patient. Zone 5, total deviation numerical plot shows the point to point deviation from the normal age matched individuals corrected normal sensitivities. So the negative decibel value indicates the depth of the field effect, and the higher the negative negative decibel value, it shows deeper scotomas. Now total deviation probability indicates the probability of the occurrence of deviations that falls outside the statistical range of the normal sensitivity. In other words, it is shown in p values less than 5%, 2%, which means that the probability of finding a defect, for example, less than 2% means the probability of finding this defect is in a normal patient this would not be present for at least 98%. Then pattern deviation numerical plot, it is derived from the total deviation plot by subtracting the generalized depression and focusing on the localized glaucomatous defect. So it is calculated by the 7th most sensitivity point. This is just an example, but it will not be always correct, because the 7th most sensitive point or 85th 85th percentile is subtracted from the total deviation plot and made it at 0. So pattern deviation probability plot increases the probability of occurrence of that deviation in the normal population. So this is what we basically use in glaucoma diagnosis. Then coming to global indices, mean deviation is actually the total average of the total. It is derived from the total deviation plot. It is average deviation from the normative data of all the threshold points except that of the blind spot. So indicates overall deviation from visual field from the normal. So this is normal hill of vision with space for the blind spot, and this shows the patient's generalized depression. And pattern deviation, pattern standard deviation is also derived from the deviation plot. It shows how each points differs from the adjacent points. So it shows localized defects of the patient. It gives an idea about the resemblance of the patient's field to the shape of the total hill of vision, but it is not used for staging or progression index. It basically shows the portholes or defects in the same vision of the patient. So this shows generalized depression with a localized scotoma. And this is generalized depression with hidden localized scotoma. The visual field index, it gives central test points more weightage. It basically sees the functioning of the ganglion cells. So visual field is VFI is 100% normal fields and 0 in perimetrically blind fields. Zone 10 basically compares the its glaucoma hemifield test. It compares the 5 zones mirror image above the horizontal meridian, superior and inferior, and it is matched with the age matched individuals. So its result comes as outside normal limits borderline. Outside normal limits, at least one zone pair differs by an amount of found less than 1% of the normal subjects, and borderline means less than more than 1% but less than that of 3%. Generalized depression, even the best test points have low sensitivity has to be seen in fewer than 0.5% of normal subjects. And abnormally high sensitivity best test points location is so high that it's not less than seen in 0.5% of normal subjects. So this is an example of, and we diagnose using Anderson's criteria. So 3 or more non-contiguous points, non-edge points in a 30-dash printout, or 3 or more contiguous points in a 24-dash printout with a p less than 5%, out of which at least one has p less than 1%. And pattern standard deviation should have a value less than 5%, p value less than 5%, and GHT outside normal limits. So glaucoma grading scale is used by Hoda Parrish Anderson criteria. So early defect is more than 6 decibel, and a cluster of which we all using Anderson criteria. And stage 2 is moderate defect 6 to 12, and stage 3 is advanced defect, and stage severe defect is more than 20 decibels. And stage 5 is end disease, and the patient is unable to perform the HVF. So this is showing a 24-2. So the central point is more affected. So we go for a 10-2 and macular split seen in the one of the macular program. Thank you.
Our next speaker is Dr. Satyan, sir. He's the director of Satyan Eye Care and president of Glaucoma Society of India. Sir is the most humble person and he's a great teacher also. So he'll be talking on structure and function correlation of glaucoma assessment and progression.
Uh, Thank you, Nimita. Wonderful to be here. It's always been a pleasure to be here in Kerala conference, and not only in the conference, being in Kerala itself is a great feeling. I've seen Nimita as a child. She graduated in the medical school, now as an ophthalmologist and becoming a glaucoma specialist under Bindu's leadership is amazing. I'm really happy to see you here, and inviting me to be a speaker in your session is a pleasure to be here. So wonderful talks, all of you have given great talks. I wish that you really go into the depth of each talk, what is really practical for people to really practice, so that we use it in our clinical, daily clinical practice, than just giving a theoretical aspects. So we'll just discuss that in case there is some time to be discussed. So looking at the structure function correlation, so how do you really relate these two together? This is like husband and wife. That is a very superficial relationship, I can say. But if you really go to the depth of it, it is more like a mother and a baby relationship for the structure and function relationship. The relationship is so deep, any change which happens in the structure, many a times we really may not be able to assess the function, or we don't know how to read the function. That's the problem we have. Because we keep seeing some talks in the conferences, or somebody has taught you something, you just follow it up. But try to apply the knowledge in everyday clinical practice so that you become much better than what the people just teach you or you read through the books. So when there is a damage, it may be a very minimal damage to the entire structure, probably has gone off. So what is the real functional change that you can really see by means of X instrument? And how much you know about that particular instrument? We have quite a good number of instruments today to either early diagnose glaucoma or pre-perimetric or even pre-OCT glaucoma. So that is the ERG, pattern ERG we have. So we can diagnose even pre-OCT glaucoma also. So it is not that number of equipments we are lagging, is that we have something, is that our axons have been reasonably stimulated to look at what is there going on. So structure function we can look at both subjectively as well as objectively by both the structure and function. So looking at the retinal ganglion cell loss, we have a lot of retinal ganglion cells, probably a million cells. I'm not sure whether you have heard my talk on million cells earlier. So we have million cells. Can we really understand these million cells, what's happening to these million cells? It is not only the glaucoma which damages the RGC. Of course, there are other reasons. There is a trauma, there is a neurodegenerative diseases, there is a vascular diseases. There is enough number of toxic optic neuropathies which we have not looked into. We know that what is Kerala famous for, what is Tamil Nadu also is famous for. But we never looked at in the OCT or the visual fields, are we really picking up these, and then we are reasonably explaining them, don't do this anymore. Or probably you just continue so that you keep coming to us. So the importance of structure function loss is where we can really understand, either first is to diagnose and to understand the severity of the disease. In glaucoma, we say mild, moderate, severe, and advanced. So we need to grade the disease so that the disease can be managed better. We need to understand what is the progression happening in the disease. It is just not enough. You see one, what you call the sheet of paper, which most of the people come with their own big files, which I never feel comfortable with. Then you just compare one with another one. It is not that. Today, the algorithms are completely different. You cannot just compare with one picture to the other picture. We need to use our systems. Each company gives their own algorithms to understand how the progression is happening in each location. The math is much more deeper than what you just compared in your papers. So the progression of the disease, understanding that is extremely important. If you don't understand that, then entire thing is just wasted. The third part is understanding the nature of the disease. Is that disease what you are really looking for, or your mind is fixed to only one thing? IOP 23, patients should be having only glaucoma. That's how we are mentally tuned to. So just get away from that first and try to understand there are many diseases can be just associated with, or there may be just no glaucoma, but maybe something else is there. So you can see here, it is very typically, you can see that there is a damage and which is picked up by the visual fields. And also, I'm a big fan of the octopus visual field, though I was a user for almost 20 years. I was using Humphreys, but I switched over to octopus. But octopus gives you amazing results. I'm not here to promote, but if you want to really realize that, then you have to buy and use it for some time. So it gives you the structural relationship also. You can see that for me it is a left bottom, and then I'm just showing you with one red arrow there. That is the damage, how it is picking up with the octopus. That is a physical damage. So this is the progression chart. If you really read only from your printouts, again there is no use. I'm really focusing on don't use the printouts. Use the machine. Try to access the machine in your own systems. And see, this is a very fantastic printout. From the machine. You can see the right eye as well as the left eye, how each location there is a progression happening. So how much is the total deviation? If you, okay, you have the other mic. Okay, let me just, you have a red one. You can see those triangles. The triangles indicate it is a different machine. It is a different octopus machine. That is 300 series, and you can see the squares. That is a 900 series. So we know each machine, which machine is being used, how it is being plotted. You can see that you have one. Yeah. Thanks. Which one? This one. There's no arrow. Arrow you cannot use. You have to just activate that. So I'm not sure whether you can see that. Anyway, I'm just sorry that. So you just see that each location, how much is the diffuse loss, and you see the LD. LD is the localized defects. That is a glaucoma specific, you can say. And you can see every time when the patient is doing the test, the initial phase you can see the triangles, the LD in the right eye, OD you see, or OS you see that the triangles, I have removed it. You can select whichever you want to see the progression. I'll show you in another chart. Is it activated now? Okay. Can you just give me this, at least this tracker? Okay, fine. So just to understand that, you can see the progression in a very detailed way. I would have been happy if the previous speaker was using it, and if it was not working, done something with it. Anyway, that's okay. We'll just manage it. So this is the serial analysis again from the octopus visual fields. So try to understand each field, which type of field you have done. Okay, this is a handicapped. So in the top one is the, you can see in the top which one, is it a dynamic one which we have done, is it a top we have done. So here you see this, what type of a visual field test has been done. It is something like a 24-2 or 30-2, something like that in the Humphreys. Here also it is given as G dynamic or G top. You see here over a period of time, each year, and how the things are happening. Everything is so important for you to understand. And also it is not enough for you to just see the progression in the OCT, but you see which location, whatever is here, you go and click this and see each location. It is usually the OCT gives you, usually the OCT gives you only the total loss. It doesn't give you each location. If you don't see each location, whichever is important for you, like superior or inferior, then again you are lost. You are not seeing the true progression of the disease. Just check whether this is the batteries. Again, not. Just at least manage it for the next presentation. So I'll just give you some examples. I'll just quickly go through that. So you can see in this patient there is a typical inferior RNFL loss, and this is a 45 years old gentleman. Period is between 21 to 23, and you see that structural damage in the fundus photo. You have to have fundus photograph as a compulsory thing, but you have to have a good fundus photograph machine so that you can really understand where exactly is the damage happening, and then have the OCT done. Try to see whether both are correlating or not. If it is not correlating, understand what is really happening. And also you see that the visual fields also correlates with the same thing. This could probably be the NTG pattern. Is it really the visual fields? This could be a AON pattern also. So we have to understand whether there is a true RNFL loss in the inferior zone in the fundus, which is really projected as the OCT and also in the visual fields. And also you see that whether there is a progression happening over a period. Not every patient is comfortable in doing the visual fields, but is that the OCT is reasonably good enough to understand the progression of the visual fields over a period of time? Definitely yes. You do the OCT, that gives you a reasonable amount of understanding how and each area or each location in the visual fields can possibly progress. That is a prediction. That is the one thing which I was just running through fast as the time was running. So you can understand that over a period of time how much is the change happening. Each location again you will have to go through. And this is the case number 2. This is a 50 years old gentleman seen in the year 2013. You can see 21 and 22 is the IOP, and this is the fundus changes. And see that there is a very stable visual fields, not changed much. Again, this is the same thing. But 2013, and you see this 2019, can you see the field change? How much it has progressed? Suddenly there is a change in the damage, where the patient was, though he was using whenever he comes for the follow-up. So I used to see the IOP as under control, but whenever he comes for the follow-up, he uses. But we are surprised to see why there is an increase in the damage. So patient can take you for a ride without you understanding anything about him. So you have to understand, so there is a huge change, but there is a red one I have put in. So that is a different field test done, though it looks like as though the fields had improved. But if you see on the top, it is a top strategy which has been used. So the top strategy will not give you much of a details. So we have to understand each and everything, whatever you are doing, so that you are in the right track. This is just to show you how you should really analyze each location and each test, whatever you are doing. So I'll just go through this. So there is a significant progression, but what has happened is once the patient was treated and advised to use it properly, now the visual fields are again stable. So we can look at each location. So again, this is the OCT to show each. What I was focusing is only on the inferior temporal and the superior temporal regions. These are the two locations where you can see the damage possibly occurring. So I'll just go through the another case. This is a case number 3. This case I'll quickly go through. So this patient is a 35 years old lady. We have seen it in 2023. It looks like there is a significant damage in the right eye, and left eye seems to be fine. This is the OCT, which really has picked up the inferior RNFL damage, and same in the visual fields. But what is interesting is in the left eye also it has picked up the change. So we have repeated the OCT in a different machine. This is the spectralis. Fortunately or unfortunately, the spectralis has picked up both the right and the left eye. There is a damage. This is the right eye, and in the left eye also there was a damage. So you can see in this there is a change which is occurring in the papillomacular bundle area. So this lady has turned out to be both having the glaucoma as well as multiple sclerosis. So slowly it is picking up in the OCT. Now she is full-blown multiple sclerosis with the optic neuritis, everything is happening for her. So this is one of the reasons why I was saying that it is just not enough. So they may be giving you some areas of changes which you may not be really understanding. You may think that is absolutely normal. So this is another one, case number 4. You can see again there is a damage. Sorry, is it going back? Okay, this is another patient. So this patient is had a trauma, but it is not only the trauma which is causing the glaucoma, but the patient had a traumatic optic neuropathy also. So you can see in day 1, 1 month and 3 months how there is a progression happening. Though the cupping is not much changed, but you see how much the OCT has changed. So trivial injuries you really may not notice. Whatever is the major injury in the eye, you will notice. But the trivial injury over the forehead and the temple is not being noticed. But you see that there is abnormal progression of the damage. But whenever you have a damage by the glaucoma, it takes about 12 weeks, 8 to 12 weeks to set in the damage. But you see this within 3 months, how much of a damage has been shown up in this. First month itself is shown up. 3 months later, it has shown up much more. So it is not enough for you to just see the damage. So is that damage because of the glaucoma, or is that damage because of the other reasons which is happening also you must pick up. So you can see that again how much is the RNFL loss progressing. Within the first month itself there is so much of a change. Usually that doesn't happen in a glaucomatous eyes. That happens only after 3 months of onset. So what I'm trying to say is, so this is one chart which gives you a quick example of, I'm exceeding my time I think. Initial phases OCT really helps you, but when the patient is having a more damage, then you'll have to go with your visual fields more so. Even before the OCT, if you want to really pick up the glaucoma, then you have to do the pattern ERG or something called as a photopic negative response, PHNR in ERG, that gives you an idea whether this patient is having a glaucomatous damage or is the cells are under stress. This we can really pick up by doing the pattern ERG. So it is just not enough for you to see the green, yellow or red. It is how your brain uses that red, green and the yellows. so that you can really pick up what is damage, what is the actual disease, and how much is the progression happening. So thank you so much.
Thank you, sir, for the wonderful talk. So, sir has taught us that not only understanding the disease is important, but also understanding the patient is also important. Any questions from the audience? No? I think so. We exceeded our time. Okay. So, sir, we have a few questions. So, since mix is actually on rise, is there any tips and tricks to identify the trabecular meshwork? Okay.
Let's focus on whatever the talks we had. So mix, I think Bindu has her IC. Any other things that you wish to ask or you want to add? Ranjini madam, we're one of the senior most. There are a lot of people, sir. You want to say something to our people? Now here it is a knowledge sharing, then you may have so much of a knowledge you may not be really sharing, but please do share, because especially the seniors, as I'm getting older, I think I'm going mad. Whatever the number of years you have is very short. It is better we teach our own children, the next generation, to become better. So that is what my focus has become now. So teach as much as possible. Madam, you should say something, what is that you have really picked up in this, your practice, so people can practice. Anything, specific points you want to say? Sir, you are one of the another senior most, both of you actually. The grade doesn't mean it is old, but okay. So again and again I'm saying that please do the gonioscopy. If you are not willing to do the gonioscopy, if you have enough money, you invest in the instrumentations and equipments. Like NIDAC has one beautiful where you can see the complete gonioscopy, color gonioscopy thing. Again, invest in the best of the technologies. I am mad using only the spectralis, because you miss, without spectralis, you miss quite a lot of stuff. But even if you have the spectralis, if your axons are not enough stimulated, you don't read what it is there. Again, looking at the visual fields, you look at the visual fields, but understand, don't read the last one. Mean deviation, you have 20 and you say the patient has advanced glaucoma, you are the most foolest person in the earth, I can tell you. But if you don't read from the top, what is the age of the patient, how much is the refraction done, everything, then you lost. Don't always go systematically. As an Indian, so the session is over, I think they switched off the mics. So as an Indian, our duty is just pick up something, what is in the end, and then we try to use it. Never use that. Go systematically. From top to bottom you read, then you will pick up a lot more. Especially on the refraction, the fixation losses, and when the patient was done, how much is the pupillary size. If you can read that first, then it gives you a lot of clues whether you really want to go through that visual fields or not. Okay, so I think it is time.
Thank you, sir. So, sir, there's a small memento from KSOS. I request Bindu ma'am. Sir.